So we're going to move on now to our fourth speaker of the afternoon, and that's Dr. Michna, who works at the Brigham and Women's Hospital. He's also the Assistant Professor of Anaesthesia at Harvard Medical School. And for all of us, this next talk, I think, is going to be extremely interesting because the pressure is on all of us to get the patients out quickly, and often this is clutching a bag of opioids on the way out. So this next talk about post-surgical outpatient opioid analgesia as a community risk.
Well, you're putting the pressure on me now. I'm not sure if that's going to work out. Anyway, so I was asked to speak about the risk of providing opioids in the post-operative period. I mean, in the United States, it's well known the severe public health issue we have with prescription opioid abuse. And recently, during the discussions, people were ready to throw away opioids. Well, I don't think I'm ready to throw away opioids on the garbage dump of history at this point. I think opioids for the significant future are going to play a role, maybe a diminished role, but still a role, certainly in acute pain, and certainly in some instances in chronic pain. The cartoon says it may surprise you to hear that actually morphine is the best medicine. Certainly, something like this, I'm not sure how blocks are going to solve all his problems. A little of my personal history. I mean, I had knee surgery for a tumor removal almost 2 years ago. And as a pain doctor, I swore, afterwards I was not going to take any pain medicine, despite them drilling deep into the knee and cavity. I had a spinal, and after the motor block wore off, I'm like, hey, this is nothing. And forgetting about the residual sensory block that was occurring. Until on the drive home, when I got home, I never experienced such agony in my life. But I still refused to take any pain medicine because I was going to gut it out. I advocate for using as minimal amount of pain medicine as possible. So I did until about midnight, after my many forays to the bathroom and cursing and expletives, and my wife and young kids were leaving in the morning for Asia on a long trip, and my wife, she's a pediatric anesthesiologist, screamed to me, take the damn Percocet already. So I did. I always listened to my wife, and that's why I got in trouble, because that one Percocet had very little effect on my pain control. It took the edge off, made me not care about it, which is what patients report. This is my first experience with my dose finding study here. But I got so damn constipated that I swore never to take another one, and I didn't. So, the point is, treatment of pain, treatment of acute pain, it's about the individual. We're all different. We all have different anxieties and needs. And it's hard to universalize approaches. So we do have a public health problem. It's well known in the United States. Now, if it was just relegated to the celebrities, maybe we wouldn't care as much. But, there's still human beings. We worry about them. The problem is the compelling stories of the deaths of adolescents and young people and the parents grieving over these deaths. It's a very compelling story. And several years ago, these farm parties, many of you probably know about it, where kids would raid the drug cabinets of their parents and grandparents, take a bunch of pills, throw them in a bowl, mix it up, everybody took a handful and partied on, except some people didn't make it through the night. A telling statistic, as a few years ago, this is really enlightening when this occurred, was that knowing the prevalence of marijuana in society, especially in the United States, as of a few years ago, pain drugs became the entranceway to substance abuse. That's an amazing thing, that where kids used to experiment with marijuana, now the first drug they're using is prescription opioids. So we have celebrities, we have young people, but the elderly are also involved in this. Now certainly the children of the 60s are now in their 60s and 70s, and that's That's part of the problem. But also there's a lot of money to be made from selling your drugs. And people, they have real problems, so they take some and they sell some. And in these tough economic times, that's how they survive. So, there's monthly reports on the age of people being caught and prosecuted for selling drugs. An 87-year-old a few months ago was caught selling their drugs. So what do we know about this problem? Very little. There's a lot of activity out there. We're passing guidelines, states and federal governments passing regulations, but we really don't understand this problem at all. What do we know? We know that the source of medication frequently is friends and family, and that's up to 70% of it. Now, of course, there's, nowadays, also in the United States, we're getting a lot of importation, particularly from China, of knockoff drugs and even more potent opioids. So as we're trying to reduce the amount of drugs on the street, entrepreneurs are filling the gap. So we also know there's a lot of what ends up on the street comes from legal prescriptions. We know there's been an overprescribing of these medicines. Dentists used to give, tens of Vicodins for a little tooth extraction or a little dental pain. We've been overprescribing these medicines. We also know that some patients benefit from chronic opioids, but many do not. That's pretty clear. And we also know that patients with psychological comorbidities do less well on opioids and are on higher doses. Ajay Wasan, who's in our practice, published a relevant article on that. So what don't we know about this problem? Well, certainly much more than we know. We don't know simply what is the rate of patients that are opioid naive, that are exposed during an acute pain, perioperative pain to opioids, then evolve into a pattern of misuse and eventually abuse. We don't know. We don't know if there's any difference in the exposure to a particular opioid. Is one worse than another? Is a particular formulation better or worse? Is slow onset or fast onset? We've developed a lot of screening tools for risk assessment, but we still don't know whether by doing all these assessments that we're really making any effect on the public health. We don't know what the incidence and overuse and abuse in chronic pain patients is either. We've instituted a lot of costly urine screens for monitoring patients, but we still don't really know if that's made any difference in our outcomes. And what's frequently lost in the press is the secondary unintended consequences of all the things we've done to try to mitigate this. And certainly there are patients that were functional before and now become dysfunctional because more and more primary care in the United States and other clinicians are refusing to write for prescription opioids. And certainly we know about the squeezing the balloon phenomenon. When they reformulated OxyContin, there was a drop in the use of OxyContin, but we also had a significant rise in the use of immediate release and very high dose oxycodone. So one action it didn't have a net effect on the public health. The effect was limited to that particular drug. So I'd like in a few seconds here, hopefully, to just talk about our chronic pain experience and opioid misuse and how that could frame some of our mitigation strategies for the acute pain. So years ago, before all this was in the press, it wasn't like we physicians didn't know things were happening. We weren't stupid. We knew patients were fooling us, they were lying to us, they were misusing drugs. So we decided to look at our physicians and to determine how likely they were, just by looking at the medical record, seeing the patient, to determine if somebody was going to end up misusing or abusing the drug. And we compared that to the nurses and the secretary at the front desk. So all you guys would probably predict the doctors were the worst, and the secretary at the front was the best. There's a lot of reason for that, because when patients come and see me, it's yes doctor, no doctor, there's no problems doctor. But the front desk, they're arguing with the secretary, they're like, where is he, why am I running late? And to be truthful, the people at the front desk live in the same neighborhood as a lot of these patients, and they're probably more street savvy than we are also about things. So then we knew we had to do, since we were so bad at picking out these patients, we had to get some more definitive data. And of course, we were using urine screens at the time, but we increased our use of them. And at one point, my boss went on vacation, and I was determined that he had so many patients that were fooling him, I was just going to urine screen everybody in the whole practice. So that's what we did, despite the protestations of the lab and our nursing. And what we found out that in our chronic pain center, and it's been replicated in other centers, there's a misuse and abuse rate of about 40%, which is a shocking number. Now that means that we define misuse as not taking the meds we're giving you, taking other prescription opioids, but unfortunately not the ones we gave you, and taking other substance of abuse. So then we decided to look at, can we take what we perceive to be high-risk patients and pay a lot of attention to them and reduce the rates of abuse? And in fact, you can. If you pay a lot of attention, spend a lot of money looking and putting people in groups, you can reduce the risk of these patients misusing medications. It mirrors, though, the education data, where people that are at risk of not graduating from high school, you spend a lot of time and attention on them. And in fact, you can get them to graduate. But what happens when they go to college? They revert back to the mean and what they would have been anyway. And same thing is with pain patients. When we stopped paying attention to them, a lot of the people that were in the study eventually got into a period of misuse and abuse. We also, and other places, have developed screening tools to help us assess whether a patient's at a low, moderate, or a high rate. And the one that Brigham developed was the SOAP. It's basically self-reporting questions, and certainly people can lie, and you don't just use one tool. But it's amazing how many people endorse reality, and these tools are validated, and they help us in determining not so much whether we're going to give opioids, but if we give them, how are we going to monitor them, and what's the protocol, and what drugs we're going to use for these patients at risk. So we developed a lot of things to try to mitigate risk. And we're running out of time. So because doctors were so bad about taking care of this problem, state and federal and other legal entities took over. And they passed a lot of legislations and regulations. And granted, a lot of those were passed in the last few years. This study in the New England Journal of Medicine showed that between 2006 and 2012, 81 new laws were passed. But in a high-risk population of disabled adults, it made no difference. It had no effect on their misuse or abuse. So we know there's chronic pain after surgery. I'm not going to talk about this. So we know there are problems in terms of getting patients into the system. And currently our surgeons don't give realistic expectations to patients. In fact, they're telling them, oh, you're not going to have that much pain, we'll take care of you, da-da-da. That's not the reality. And they also fail to ask questions about past dependence issues. And that's a problem. So there's no screening at all of these patients. And we have to deal with these patients after they've been surgerized and then have complications and misuse and overuse. So basically, this is addressing a problem with the horse out of the barn. And what we've tried to do recently is to change that, to pay more attention to the preoperative period, to try to assess risk before we have surgery, and to set the right expectations. And for those that are at risk, we're going to pay particular attention to them in the postoperative period. So we have teams that meet with patients and they set realistic expectations for postoperative pain. We we haven't yet, but we are going to try to risk assess patients before surgery and identify those who are at high risk. And we'll try to follow those patients closely to minimize their opioid exposure during the surgery, post-surgery, and then try to get them off opioids as soon as possible. Our proposal was to use technology like phone apps to better follow these patients because it's frequently, the cost issue is prohibitive. As Sean was saying, that the pre-op clinic already saying we don't have time to do all these kind of battery of tests and assessments. So you run into that brick wall. So we're attempting to get by that and try to get better results from that. So to end is talk about the unintended consequences. We've done all these things. How many people have we taken off opioids that ended up buying drugs in the street, going to heroin? And is that a better or worse problem? I don't know. And certainly there are a lot of people suffering that were stable on 3 Percocets a day, old ladies. I have old elderly ladies in our community that are actually buying Percocet on the street because nobody will write for them. Is that a good thing? Are we doing a good thing there? Probably not. So I think we always have to look at, as a lawyer, we always know there are secondary unintended consequences to anything we do. And sometimes you can identify those before, but sometimes you can't. So you have to really look at the effects long term. Unfortunately, it takes 5 to 10 years to realize what you've done. Thank you.
Thank you.